How often do the oncologists do a new biopsy after first line fails or
Always.
progression?
If the patient comes back for distal metastases with for breast cancer, guidelines are to biopsy the distal metastasis every time.
Every single time.
I mean, once the patient's progressed, let's say patient had surgery, they had a diagnosis in 2016, they had a recurrence in June of 18. In June of 18, they get a biopsy of the distal met. But, and then they go on to get second-line therapy. But if the patient progresses further, let's say late, or doesn't respond to second-line drugs in June of 18 and continues to progress in December of 18, you don't need a third biopsy in December of 18. But so in this kind of, the first distal recurrence, most patients undergo a tissue biopsy by guidelines.
By guidelines. And then is there more often a second one? I'm just thinking about at launch, would they be going back to the most recent tissue prior to first line therapy, or would they be taking a fresh tissue or using plasma?
Fresh tissue. Getting plasma, everybody gets a stick, so getting plasma is a non-event. You can, whenever the patient comes, they always get, blood drawn for all kinds of tests. Right. So getting plasma is
easy.
Every doctor's visit, you can get plasma. But for when there is a distal recurrence, patient by guidelines should have a second biopsy.
Okay. And how do you become aware of these new targeted therapies, or how would you go about making the decision to add PIK3CA to that routine panel that you were talking about?
Through medical literature, we have a multidisciplinary boards. So if there's any practice-changing piece of evidence which changes both their therapeutic options and diagnostic, algorithms, then we discuss it in tumor board, and if we need to change, we do.
Okay. And does pharma engage with you on a regular basis, or do you hear from pharma reps or emails, or is there any way that pharma reaches out?
Answer they don't, but yes they do. But most of the big pharma companies now have either acquired or mostly they have gone out and acquired diagnostic companies. Mm-hmm. Like Genentech has Roche, and Roche has Dako, and so on and so forth. So they have their own diagnostic companies because they want to be in control of their companion diagnostics, basically. Right. So those people will focus on pathologists and come and give us, informational lectures and so on and so forth if something new, something changes.
Okay. And how much do they talk about the therapies? Do they really focus on the diagnosis?
It's like you can't really talk one without the other. The whole point of doing biomarker testing is to, they all what we call predictive tests. The purpose of doing the test is to guide therapy. There is no second purpose.
Right.
So yes, they talk about therapeutics, and you can't, when you go to the med-onc, you really can't talk about the therapeutics absent the diagnostics. They need a positive result to give the drug. Mm-hmm. So it's like, that's why it has to be multidisciplinary, and the decision is also multidisciplinary.
Gotcha. Is there one company that stands out, if you don't mind sharing, that works with you in the most effective way?
What kind of company?
So where it could be a pharma company or a diagnostic company where you think it's really effective the way they call on you or make you aware.
Genentech works really well because they have numerous CDK4/6 inhibitors now, and then they now also they always have the anti-HER2 therapies. So they have a very strong pathology sort of outreach force. They knock on our doors and give us lectures and so on and so forth.
Gotcha. And have you seen that recent announcement around Roche acquiring Foundation Medicine in its full?
Yeah, I did see it. Mm-hmm.
Yeah. And how have you heard from? Have Foundation Medicine reps called on you?
Not really. No.
Not really.